Welcome back to part two. I hope you had a lunch break and you relaxed a little bit and enjoyed the pre-recorded excellent presentations. So we're changing a little bit the concept in this part. We're going to be debating clinical decisions in this part. I think Michalis is going to give you an introduction about it and present the panelists, at least part of them. So Michalis. I think you're...
Thank you, Sophocles. And everybody, welcome back. Moving on to part two, the first part of part two, actually. We're going to move on to a presentation by Mr. Metaxas. Before we do that, I would like to present to you the panelists of this part two, the people who are going to ask for their decision, for their opinions on the cases. Give me just a second, please. I need to switch on my screens here. Yeah. So we're still going to have Mrs. Floredia Fostira with us, our clinical geneticist. Bahadir Guluoglu, who is a fellow breast surgeon from Istanbul. Hi, Bahadir. Dr. Yersim Eralp, who is a medical oncologist from Turkey. Hi, welcome. Hi, Yersim.
Kalimera.
Kalimera. Dr. Jamil Al-Azri, who is a surgeon as well. Hi, Jamila, welcome aboard. And Dr. Welcome. And Dr. Thodoros Kondoulis, who is a very experienced surgeon from Thessaloniki. Hi, Thodoros, and Vice President of the Hellenic Society of Breast Surgeons. And Sophocles is going to present the rest of the panelists.
I will start with Thorsten this time because we're gonna also have Thorsten in this part too. So Dr. Kuhn, you know him already and you know his contribution to the webinar. We're gonna change a little bit in terms of the radiology oncology. We're gonna have Mr. Evangelos Maragoudakis with us. And we're gonna have a breast surgeon, Fiorita Boulakaki, with us from Greece, but well known to the international stage. And we're gonna have Dr. Toralf Reimer with us, who's also a breast surgeon.
Hi, Toralf, welcome.
And finally, gonna have Nicola Rocco, a breast surgeon from Italy.
Hello, everyone.
With us.
Hi, Nicola.
Obviously enjoying the nice weather in Italy this time, I guess.
Yeah.
And before we move on, I just have to say, because maybe Bahadir missed in the first part, Bahadir was the reason why we became international in this webinar, because he actually, in brackets, forced us to do it in English and get lots of faculty members to join us. So thank you, Bahadir, for that.
It's a pleasure always. You know that when you started this, I think 3 years ago, it was a very good initiative for the region to start this collaboration between the medical oncology, not only internationally, of course, between the disciplines. So I'm seeing that every year you're improving more and more, and you're bringing really very challenging cases to discuss. And we know that we're not discussing anything issue which is straightforward. Here is what you're seeking is the experience. And thank you very much for just, inviting me as well to be a part of this as well.
Thank you very much. Michalis.
I think, Sophocles, it's your turn to introduce Yorgos Metaxas.
Okay, then. So we move on with the webinar. As I said, we're a little bit behind, but I think it's worth the effort. And I'm going to introduce now, I'm going to call to the podium George Metaxas, who's a breast surgeon from Greece, trained in England. So he's going to talk about the contemporary staging of the lymph nodes and how to manage this staging to tailor systemic therapy. George.
Thank you, Sophocles. Lots of information together in this presentation. I have pre-recorded my presentation also. So if that's okay, we can start with the pre-recorded presentation. Thank you for the
Good
invitation
afternoon,
also.
everyone. Thank you for being here today. In this presentation, I will discuss contemporary lymph node staging and management, tailored systemic therapy, an important subject that has significant relevance in our surgical practice. The purpose of the presentation is to provide an overview of the topic, highlight key concepts, examine the relevant findings, and discuss potential implications. Early breast cancer accounts for the majority of breast cancer diagnoses, representing approximately 92% of all cases. Hormone receptor and HER2 status are critical for guiding treatment selection. Among breast cancer subtypes, HER2 positive disease generally has the most favorable prognosis in the metastatic setting, largely due to the effectiveness of targeted therapies. The diagnostic workup may include mammography, ultrasound scan, and MRI. MRI can support assessment of eligibility for neoadjuvant therapy and treatment response. MRI assists in defining the extent of resection for surgical planning. Following neoadjuvant chemotherapy, MRI demonstrates sensitivity over 90% for detecting residual disease and specificity less than 6% for predicting pathological complete response. A negative MRI scan does not exclude residual microscopic disease. Several key factors influence decision-making in axillary management, including tumor biology, clinical presentation, and the sequencing of surgery and systemic therapy, the extent of the technique of axillary surgery, and the input from the MDT. Importantly, the morbidity associated with axillary intervention should be carefully considered when selecting the optimal treatment strategy. The diagram depicts the evolution of axillary management over 3 eras. First, the routine full nodal clearance era. Second, the cell lymph node biopsy and post-neoadjuvant chemotherapy de-escalation strategies era. And third, the current precision medicine era, characterized by increasingly individualized treatment pathways. When suspicious axillary lymph nodes are identified, an image-guided biopsy should be performed. The most suspicious nodes should be marked, clipped, before initiating treatment. During surgery, the clipped node should be removed together with the senile lymph node as part of targeted axillary dissection. Molecular profiling of lymph nodes is not routinely performed. However, it may be useful in selected cases to identify discordance with the primary tumor, detect actionable biomarkers, and guide treatment decisions. Assessment of both the primary tumor and axillary lymph node metastasis is recommended in preoperative core needle biopsies when significant morphological discordance is present. Several landmark trials have supported the de-escalation of axillary surgery in early breast cancer. The Almanac trial was among the first to demonstrate that senile lymph node biopsy is associated with significantly lower morbidity and better quality of life than axillary lymph node dissection, establishing senile lymph node biopsy as the preferred staging procedure for patients with clinically node negative early stage breast cancer. The Z11 trial subsequently showed equivalent 10-year overall survival and local regional control in patients with T1, T2 breast cancer and clinically node negative axilla who were found to have 1 or 2 positive nodes and underwent either senile lymph node biopsy or axillary node clearance. Similarly, the Amaros trial compared axillary dissection with axillary radiotherapy in patients with positive axillary lymph nodes in senile lymph node biopsy and demonstrated comparable axillary control with substantially lower rates of lymphedema in the axillary radiotherapy group. More recent trials have further supported axillary de-escalation in selected patient populations. The CENMAC trial demonstrated that omission of axillary dissection was not inferior to completion of axillary dissection in patients with clinically node negative breast cancer and senile lymph node macrometastasis. Importantly, the study included patients undergoing mastectomy, with approximately 1/3 patients treated by mastectomy, 6% presented with T3 tumors, and the majority receiving adjuvant radiotherapy. The SOUND trial randomized more than 1,400 patients to receive senile lymph node biopsy versus no axillary surgery and showed that in patients with small tumors and a negative axillary ultrasound, omission of senile lymph node biopsy was not inferior in terms of disease-free survival and overall survival, supporting further surgical de-escalation in carefully selected patients. Similarly, the INSEMA trial demonstrated that omission of axillary staging surgery is clinically node negative patients was not inferior to senile lymph node biopsy with respect to oncological outcomes after a median follow-up of 6 years while reducing surgical burden and treatment-related morbidity. In the adjuvant setting, we learned that leaving residual axillary disease in the form of non-senile lymph node metastasis does not necessarily compromise oncological outcomes, while substantially reducing treatment-related morbidity. The post-NOC trial is expected to clarify whether axillary intervention can be safely omitted in patients with low-volume nodal disease receiving modern systemic therapy. But what happens in the neoadjuvant setting when a patient is a candidate for neoadjuvant chemotherapy? Patients are initially classified as clinically node negative or clinically node positive and undergo the same clinical imaging and pathological assessment of the breast and axilla before treatment. This baseline evaluation is crucial as it guides treatment selection and determines the appropriate strategy for post-treatment axillary management. Neoadjuvant systemic therapy frequently results in significant downstaging of disease within both the breast and the axillary lymph nodes. The achievement of pathological complete response, particularly in HER2-positive and triple-negative breast cancer, is a strong predictor of favorable prognosis and creates opportunities for less extensive surgical management. Following treatment, the surgeon must decide whether axillary staging can be performed with sentinel lymph node biopsy or target axillary dissection, or whether axillary lymph node dissection remains necessary. When sentinel lymph node biopsy or target axillary dissection is selected after neoadjuvant chemotherapy, special attention must be paid to minimizing the false negative rate to ensure accurate assessment of residual nodal disease. Conversely, patients with persistent nodal involvement, macrometastasis after neoadjuvant chemotherapy, or those presenting with a high initial axillary tumor burden generally remain candidates for axillary lymph node dissection. Post-neoadjuvant chemotherapy imaging for residual disease shows low sensitivity, and axillary surgery remains essential for both clinically node negative and clinically node positive patients to diagnose and treat persistent regional nodal disease. These three landmark post-neoadjuvant trials were the first to demonstrate that sentinel lymph node biopsy after neoadjuvant chemotherapy is feasible with satisfactory sentinel lymph node identification rates. However, they also reported relatively high false negative rates of approximately 13 to 14%, exceeding the accepted threshold of 10%. The false negative rate was particularly high when only one sentinel lymph node was retrieved and decreased substantially when 3 or more sentinel lymph nodes were examined, falling to below 10%. Interestingly, a later meta-analysis reported a false negative rate of 13% for post-neoadjuvant chemotherapy sentinel lymph node biopsy. Despite this diagnostic inaccuracy level, at the time it was considered clinically acceptable given the low rates of axillary recurrence and the morbidity associated with axillary lymph node dissection. In 2017, the first large prospective study on targeted axillary dissection was published. The technique combines clipping of the biopsy-proven metastatic lymph nodes before neoadjuvant chemotherapy with selective removal of the clipped node and sentinel lymph nodes after treatments. This approach was shown to significantly reduce the false negative rate compared with the sentinel lymph node biopsy alone. At the same time, it became increasingly clear that false negative rates exceeding 10% should not be considered acceptable for routine clinical practice. Furthermore, despite growing evidence supporting axillary de-escalation, there remains no level 1 evidence supporting the omission of axillary lymph node dissection in patients with residual nodal disease outside the setting of prospective randomized clinical trials. The change in practice and the visible reduction of axillary lymph node dissection has been underway since 2013. That is, despite the high false negative rates and the lack of data from prospective studies after Z11 and Sentinel, even in pathologically positive nodes after neoadjuvant chemotherapy. This was followed by studies demonstrating safety for sentinel lymph node biopsy in pathologically negative patients after neoadjuvant chemotherapy, as well as a study showing the extremely low nodal recurrence rate after neoadjuvant chemotherapy, sentinel lymph node biopsy with 3 or more sentinel lymph nodes negative, but also studies that raised concern about axillary lymph node dissection omission in patients with residual nodal disease after neoadjuvant chemotherapy. In the battle of de-escalation, the controversy between target axillary dissection and sentinel lymph node biopsy in a 10-year follow-up showed equally good results with less than 2% axillary recurrence. Furthermore, a comparative study evaluating target axillary dissection alone had similar rates of survival and recurrence compared to completion axillary lymph node dissection, suggesting that completion axillary lymph node dissection may not provide additional oncological benefit in selected patients undergoing targeted axillary surgery. More recent studies have highlighted an increasing interest in de-escalating axillary surgery and potentially avoiding axillary lymph node dissection in selected patients with residual nodal disease after neoadjuvant chemotherapy, although definitive evidence supporting omission of axillary lymph node dissection in this setting remains limited. The data support that skipping axillary staging is safe in the adjuvant setting in T190 patients with clinically negative axilla, as well as in patients over 65 with low-risk ER-positive disease. These findings have already been incorporated into international guidelines. In the neoadjuvant setting, both the ICARO and MicroNAG study do not support axillary lymph node dissection for residual micrometastasis or isolated tumor cells. In any case, when positive nodes remain positive after neoadjuvant chemotherapy, guidelines still recommend axillary lymph node dissection. The Alliance trial is expected to generate level 1 evidence for omitting axillary lymph node dissection or not in T13N1 patients who remain node positive following neoadjuvant chemotherapy. Neoadjuvant chemotherapy can downstage the axilla and may inform the extent of axillary surgery in selected patients. It is primarily indicated in HER2-positive and triple-negative tumors over 2 cm regardless nodal status, but also in clinically node-positive patients expected to achieve nodal downstaging after treatment. In HER2-positive and triple-negative patients, the anticipated nodal PCR is up to 65%. Therefore, accurate pretreatment axillary staging is essential to guide treatment planning, assess response, and optimize surgical management following neoadjuvant therapy. Since 2019, early analysis of Keynote 522 trial have shown a significant improvement in PCR, particularly among patients with higher PD-L1 expression. Benefit was also observed in patients with positive lymph nodes and across all disease stages, contributing to meaningful surgical de-escalation. Neoadjuvant chemotherapy combined with HER2 targeted therapy is the standard of care for patients with stage 2-3 HER2-positive breast cancer. This approach significantly increases pathologic complete response rates. Key regimens commonly include taxane-based chemotherapy plus dual HER2 blockade with trastuzumab and pertuzumab. Common protocols include TCHP, docetaxel, carboplatin, trastuzumab, pertuzumab, or anthracycline-containing sequential regimens followed by HER2-targeted therapy. Major trials such as the Neosphere and Trifina demonstrated high PCR rates with dual HER2 blockade, establishing neoadjuvant treatment as a cornerstone of management for HER2-positive disease. An axillary response to neoadjuvant therapy may result in the escalation of axillary surgery from dissection to cell lymph node biopsy. Not all patients, however, achieve PCR. 34 to 61% have residual disease. This matters because pathologic response after neoadjuvant therapy directly informs prognosis and post-neoadjuvant treatment selection. Recent PCR after neoadjuvant therapy is associated with improved long-term outcomes and treatment de-escalation. With existing regimens, 39 to 64% of patients have PCR. Rates are lower in patients with hormone receptor positive disease and those who have a higher risk of recurrence. In real-world practice, a substantial proportion of patients meeting high-risk criteria do not receive neoadjuvant therapy. Early MDT discussion is critical to ensure eligible patients are offered neoadjuvant therapy before definitive surgical planning. Evidence from TRAIN-2 trial supports that anthracycline-containing and anthracycline-free regimens with dual HER blockade can achieve similar efficacy outcomes, although safety profiles differ. Neoadjuvant standard of care for HER2-positive early-stage breast cancer is trastuzumab and pertuzumab with polychemotherapy. However, existing regimens have high toxicity burdens and suboptimal outcomes. Destiny Breast 11 trial assessed efficacy and safety of neoadjuvant trastuzumab deruxtecan alone or followed by paclitaxel, trastuzumab, and pertuzumab versus dose-dense doxorubicin, cyclophosphamide, followed by THP for high-risk HER2-positive disease. This trial randomized adults in 3 groups: TDXD alone, TDXD THP, and DDAC THP. The trastuzumab deruxtecan alone arm enrollment closed early following the Independent Data Monitoring Committee recommendation. The primary endpoint was pathological complete response with secondary endpoints, event-free survival, and safety. Neoadjuvant trastuzumab deruxtecan THP demonstrated a statistically significant and clinically meaningful improvement in pathologic complete response versus DDAC THP in both the HR-positive and HR-negative subgroups with similar safety profiles. HER2-positive early breast cancer patients with residual disease after neoadjuvant chemotherapy are at high risk for recurrence. In Destiny Breast 05 trial, the authors investigated post-neoadjuvant trastuzumab deruxtecan as compared with trastuzumab emtansine, the current standard treatment in patients with HER2-positive breast cancer with residual invasive disease and node-positive disease at surgery or inoperable disease at diagnosis. The primary endpoint was invasive disease-free survival, and the key secondary endpoint was disease-free survival, including survival-free from non-invasive breast cancers and second primary non-breast cancers. Other endpoints included overall survival, distant and recurrence-free interval, brain metastasis-free interval, and safety. In these high-risk patients, the majority had positive post-neoadjuvant therapy pathologic nodal status. In patients with high-risk residual invasive HER2-positive breast cancer, post-neoadjuvant trastuzumab deruxtecan resulted in significantly higher likelihood of invasive disease-free survival than trastuzumab emtansine. Toxic effects were mainly gastrointestinal and hematologic, as well as interstitial lung disease, which requires appropriate monitoring and management. Overall, the study demonstrated a 53% reduction in the risk of invasive disease recurrence or death for trastuzumab deruxtecan compared to trastuzumab emtansine. Based on the results of DESTINY Breast05 trial, trastuzumab deruxtecan has been included in the NCCN clinical practice guidelines in oncology as a Category 1 recommended treatment in the adjuvant setting for patients with HER2-positive early breast cancer with residual disease and high risk of recurrence following preoperative chemotherapy. The modern landscape of axillary surgery is characterized by progressive de-escalation aimed at minimizing morbidity without compromising oncologic outcomes. Sentinel lymph node biopsy has largely replaced the routine axillary lymph node dissection in clinically node-negative patients. The increasing use of neoadjuvant systemic therapy has further reduced the need for extensive axillary surgery through nodal downstaging. Current strategies emphasize tailored, response-adapted management, integrating imaging, tumor biology, and treatment response to optimize patient outcome. Thank you very much for your attention.
Thank you, George. That was a very condensed speech about everything that we had to hear about the strategy of staging the lymph nodes. So gonna just carry on with the next case, which is quite relevant, I guess. So we're gonna be discussing a T2N1 tumor, which is ER positive, HER2 negative this time. I know there are some similarities with the triple negative one we had previously, but there are some differences, and I think these differences, they quite made a lot of difference in the management of these patients. I can though, okay. Can you see my full presentation here?
Yeah.
Yes. Okay. So let's carry on. So we have a 50-year-old perimenopausal lady with a C-cup breast size who presented with a palpable lesion in the right upper quadrant of the breast. Nothing abnormal for the past medical history, family history unremarkable, and on examination, she had a lesion in the upper outer part of the right breast. It was palpable, measuring about 35 millimeters. The skin was normal, and the lymph nodes were mobile, palpable, and abnormal in the right axilla. So on imaging, there was a single lesion in the upper outer part of the breast, measuring 35 millimeters. The skin was normal, as I said. The lymph nodes were 4 abnormal axillary lymph nodes. The maximum size was 1.6 centimeters. Yes, 1.6 centimeters. So a core biopsy from the breast and the axilla. It was non-specific type of grade 3, ER positive, 90%, PR 70%, HER2 3, score 3, so HER2 positive, and KI 67, 50%. So overall, we had a T2, CNE plus, M0, a non-specific type grade 3, ER positive, HER2 positive tumor. So according to what we have said and to what we know, this patient is a very good candidate for neoadjuvant chemotherapy. There's no discussion about that anymore. So the question is how we're going to plan the future for this patient. Are we going to mark one single lymph node and do TAT? Are we going to mark more than one lymph node and still go for TAT? No marker. Since we have 4 lymph nodes, we're going to go for axillary lymph node dissection, post-neoadjuvant chemotherapy. Obviously, you didn't expect us to get one lymph node positive. We went for something bigger than that. So let's get the poll box and vote. What would you do in this case? So as soon as we get the results, I would ask Fiorita Pulakaki to comment on this first of all. So let's get the results, please. Okay, divided. This is the aim of this webinar, to get you all divided here. So Fiorita, 30% chance to get one of these 3 options. What would you do, first of all?
Hello, everyone. Thank you, Sophocles and Michalis, for the invitation. I would probably go for a no marker since we have this block. I realize that it's four lymph nodes and it's not fixed. But it's blocked. It's all together. I think that cost-wise, it would be in most of the countries very, how can I say, very costly to put four markers. We can definitely go with carbon, but since most of the countries use this specific marker, this clip marker, which is quite costly, I would suggest that very few of us would regard going only for TAD in this case. I would definitely go for an axillary lymph node dissection post-NAC.
Okay, thank you, Fiorita. Would anybody else from the panel vote for marking one lymph node just to support the 32%?
No.
Nobody. Okay. Toralf, please.
Yep. I voted for option number one because, yeah, I know it's not the best candidate to do a TAD because we have more than 3 suspicious lymph nodes, but we have now larger inclusion criteria for the Axana registry trial, and I think we will get data for patients with 4 suspicious lymph nodes in this case, and this is a very good case, a very good candidate for neoadjuvant systemic treatment because it's triple positive, and I expect a high rate of complete pathological response in the axilla. So I would place one marker in the most suspicious lymph node and then wait for axillary response. And then at the end of neoadjuvant systemic treatment, we can decide what we should do regarding axillary surgery. But if we have the marker inside, we have still the option to discuss TAD.
Thank you very much. Is anybody in favor of clipping, for example, 2 lymph nodes? Bahadir, what do you think?
Thank you very much. But before, can I ask a change on these, options here? Because you said the third one is no marker, but no sentinel node either. So this could be one of the options for this patient as well. No marker, but you can do a sentinel lymph node biopsy with, 2 agents. And then if it turns out to be negative, then you may omit doing axillary dissection in this case as well. Although my option was number 2, and the reason here is that after B51 study, we are now discussing about omitting radiotherapy in these patients as well. So I know that the inclusion criteria for that study is not that just, fitting there, because we have here 4 lymph nodes, suspicious lymph nodes, although not all of them are biopsied, as far as I understand. Is that correct? Yeah.
No. Yeah, they're not
Of course.
biopsy.
This is only clinically positive. Is that
Yeah.
correct?
Yes.
Yes. Okay. So here, the reason is because I was not doing targeted axillary dissection for the last, 6-7 years, but now I returned back this practice to my, an option to my practice. Why? Because my radiation oncologist now, asks me that to prove that there is no residual tumor in the axilla. So that is why if you have this number of, abnormal lymph nodes in the axilla, then I'm doing is that the most largest one, I put a clip or any marker, could be, whatever you use in your clinical practice. And also we are putting through the lymph node, which is suspicious at the top, the upper part. So in order to fix these 2 points in the axilla, we're using also routinely ultrasound during the operation. So we can find these nodes, because in the beginning, these are suspicious, but this is an HER2 positive, patient. So that means that 70%, 60 to 70% of the time, there will be downstaging of this axilla, whether this is 4 node positive or 1 node positive, because we know that from ASCO, that the Axana also showed us that it doesn't matter whether the number of lymph node suspicious nodes, it's all whenever they get the neoadjuvant chemotherapy or systemic therapy, they have the same effect of downstaging. So that is why I just marked the option 2. So I mark only 2 nodes here, the upper one and the most suspicious one.
Thank you very much, Bahadir. And that, of course, we give explanation for each one of these answers. There's no correct or wrong answer in this case, as you can tell. So what if we had 4 lymph nodes, but they were in block? So we have a block of 4 lymph nodes, but it's not fixed. So this is the confusion in the literature, whether that is a CNE2 disease or whether that is a CNE1, since it's not matted and fixed, and just 4 lymph nodes that they are all matted together. So the question, would you mark one and do TAT, or no marker, exactly the same question, and go for axillary lymph node dissection? So let's vote now in this scenario. Can we get the poll box, please? Nikolai, it's your turn, as soon as we get the results, you're going to be
Yeah, thank you.
requested to answer. Okay, let's get the results, please. 50-50. Okay, so what do you think? What would you vote?
Yes, no, I can tell you that I would like just to comment in general before telling what is my opinion, because I think my opinion is that is not on counting the lymph nodes, the exact staging of the axilla, because we know that the clinical staging, the staging of the axilla is clinical. So if the lymph nodes are mobile, are not fixed, as you correctly underlined, this is a borderline CN2. So I would also consider, even if there are 4 lymph nodes, as also Badir already said, that we can also consider not putting a marker, but not going for an axillary lymph node dissection, but for a sentinel lymph node biopsy with a dual tracer. That it is what we usually do here in Italy. And I can tell you, not in these borderline cases, we are still, in these cases, we are still using a dual tracer, but in CN1 cases, turning into N0, we are also using, as Giuseppe already said before in the first panel, also one tracer. Because, yes, anyway, I'm going outside of this case. I would go for no marker and sentinel lymph node biopsy with dual tracer in this case. So I didn't give an answer. None of
Thank you
these
very
two.
much.
Yeah.
Jamila and Fiorida agrees with you, but I think Zahariudagis is quite skeptical. So, Konstantinos, what would you do? Would you mark or not mark these lymph nodes?
Well, we would mark an N1 patient with a single MAC seed, but in this case, because it's borderline N2, it's a bit unclear now if this is considered, because it's a block, but it's not fixed. I would probably go for an ANC in this patient, post-NAC. I wouldn't do a simple sentinel lymph node biopsy. But yeah, I would go for a marker on one lymph node and TAD, but that's a bit borderline because you could argue this is like a N2 case, clinically N2. So most likely ANC.
Thank you very much, Kostas. Does anybody from the panel has any other opinion? Shall we carry on? Shall we carry on? Because we have a lot of questions, I think. Let's crack on.
Is Jamila wanting to?
I don't know if anybody raised their hand.
Jamila is wanting to answer.
Can I comment?
Yes, of course.
So the question is about if it's an N2 disease, and we know from the Z1071 that the false negative rate for sentinel lymph node biopsy in N2 was 0 compared to N1 disease. So if it is there, you're going to find it there. Plus, we have also the prospective NEO CentiTurk trial. Almost 20% of their patients were N2 disease, and they didn't find any difference between TAD and sentinel lymph node biopsy, whether in the axillary recurrence or the disease-free survival. So it's also oncologically safe. Given the fact that this is a HER2 positive disease, we have almost a 50% chance of PCR in the axilla, right? So we will deprive the patient from de-escalation of the axilla if we go ahead and do axillary dissection without a sentinel. And also the Axana trial showed that 35% of patients are overtreated when they go for axillary dissection after chemotherapy without sentinel lymph node biopsy. So because of the options, I would vote for the marker for one node, but in our clinical practice, we still do sentinel lymph node biopsy, dual tracer, retrieving 3 nodes at least.
Thank you very much for the comment. Let's go to the next what if. So no marker, this is the case now. So you didn't put a marker in and you got a complete clinical and imaging response. So obviously that's the scenario we were talking about. Yeah. So the question is whether you're going to do what you actually said now. So remove more than 3 nodes using dual technique and etc. Or still, because there's almost 0 evidence, just to an axillary lymph node dissection. Obviously there was a partial answer of this one. But let's see if you have persuaded the audience about your opinion. So let's vote. Let's get the poll box and see whether the audience was persuaded that we can do something less than TAD or less than axillary lymph node dissection. Okay, let's get the results, please. Okay, most people were persuaded by the previous discussion that if they don't put a clip and they get a complete clinical and image response, they can still go on and do a central lymph node biopsy by using a dual technique and removing more than 3 lymph nodes. Okay, Fiorita, what do you think? Do you agree with that?
Yes, I absolutely agree. Since we know even from the Sentina times, from the ARMC, that post-neoadjuvantly, if we retrieve more than 3 lymph nodes with dual technique, we actually have a very reduced false negative rate. So I would feel quite confident with after using dual technique to perform a sentinel lymph node biopsy and not an axillary lymph node dissection.
Thank you very much. But I will go back to Nicola. Nicola, do we have any evidence that having 4 lymph nodes with all this fibrosis causing after the chemotherapy, do we have any good evidence that we can still go on and do central lymph node biopsy with 4 involved lymph nodes?
Well, we do not evidence from, yes, can you hear me? We do not evidence from the trial, the Sentina trials, the ACOSOG 1071. But anyway, as also Viviana Galimberti from the European Institute of Oncology in Milan says in her paper, I think we are looking at the wrong outcome. We should not look at the false negative rate, but at the local regional recurrence rate. And in this case, we have evidence not now in enough patients, N2 or N3 patients, but for sure in N1 patients, that we should not look at reducing the false negative rate, but looking at the local regional recurrences. And we also have data at 10 years, and we do have very few local regional recurrences. So I would safely de-escalate surgery, even if because in N2 patients are outside of the B51 criteria, so they will also undergo regional node irradiation. So I would feel safe in de-escalating surgery.
Thank you very much. So I will carry on and go here. So we had a neoadjuvant chemotherapy, we had a complete clinical and imaging response, we have a PCR in the breast. I know that this is an unlikely to be as a scenario, but still we got 1 micrometastasis out of 4 lymph nodes in the axilla. We briefly discussed this case previously in the triple negative cancer, but this is a near positive, HER2 positive cancer, is completely different. So Toralf, what do you think? If we go here in the management of the axilla, shall we do radiotherapy in the axilla and regional lymph node irradiation? Shall we do an axillary lymph node dissection or just observation? First of all, we will vote, and then I will probably ask you to comment on the results. So it's a bit strange here because it's wrong. So 1 would be radiotherapy in the axilla, 2 would be axillary lymph node dissection, and 3 will be observation. Okay? No, just to make things simple, just keep it as it is. 2 radiotherapy to the axilla. Sorry for that, is a mistake in the management of this slide. But let's vote, having 4 options. The 1 is do not use 1 as an option. 2, 3, and 4. Let's get the poll box, please. So choice 1 is not viable. Don't use it. Choose from 2, 3, and 4. And sorry again for that. Can we get the results, please? So still some people voted for 1. Okay. So radiotherapy in the axilla and regional node radiation, that was the majority, and almost 1/4 voted for axillary lymph node dissection. So, Toralf.
Yeah, is an excellent borderline case. Following the German guideline, we have a plus-minus recommendation in this case with detected micrometastasis in the axilla after neoadjuvant treatment. So we have to discuss this with our patient because this patient, I think, is 50 years old. So I personally prefer to do the completion axillary lymph node dissection. We don't have really good data from prospective trials for option number 2. We are waiting for the Alliance trial, but this is a case with micrometastasis only. But it's a little bit different if you compare the rule of micrometastasis in the primary surgery scenario. So I think we have 3 options, and we have seen the results. And but I personally prefer the completion axillary lymph node dissection.
Completion. Okay. And Thodoris Kontoulis,
Yes.
are you in favor of axillary lymph node dissection or radiotherapy in the axilla and regional node?
Yes, Sophocles, I would go for radiotherapy, because here is a gray zone and sophistry. We have biological that resembles near PCR or true resistant disease. We're not sure. There is evidence supporting the escalation with retrospective studies showing that radiotherapy after TAD has very low axillary recurrence rates. And in that case, we have adequate sampling, we have the 4 lymph nodes, we have PCR in breast, and if we have also the clipped nodes retrieved, I would go for a radiotherapy.
Thank you very much. I will not ask now Dr. Maragoudakis to comment, because I will ask him to comment on the next question. So let's carry on. And what if we have, as before, 1 isolated tumor cell out of 4? The same questions again, now with the correct numbering. Hopefully we're going to get it right now. 1 radiotherapy as before, 2 axillary lymph node dissection, 3 observation. From what you can recall, previously you voted for radiotherapy in the axilla and nothing else. Let's see now, let's see the poll box again. Okay, let's vote. And I would like Dr. Maragoudakis to comment on the results of this poll, please. Let's get the results, please. Okay.
Okay.
So we're back to 14% axillary lymph node dissection.
Hello,
So,
everybody. This is Dr. Maragoudakis. I both voted in both cases, either the micrometastasis or the cells found on the lymph node. I would vote for radiotherapy in the axilla and regional nodal irradiation. I wouldn't like to have an extra operation, since the patient will be irradiated to the breast, so it's not a big deal to include the remaining fat of the axilla, and it seems to be safe enough to trust radiotherapy.
For both ITC and micrometastasis, you would manage both in the same way.
Yeah, I don't like the idea of having remaining disease, either clinically or in the images. If it is microscopic disease, then radiotherapy is good.
Okay, Jamila, do you agree with that? Would you operate on this axilla and do axillary lymph node
I actually
dissection?
voted for both scenarios. I voted for radiotherapy to the axilla. Actually, the question is, what is axillary dissection going to add to the clinical decision making? Because when you're doing axillary dissection, you're looking for upgrading the stage of the lymph nodes, right? And we have seen from different studies like the SNFINAC and even the Alliance trial that was presented earlier, that the number of additional lymph nodes in the axilla were not related to the size of metastatic deposit in the lymph node. It was related mainly to the number of positive lymph nodes with macrometastasis and related to the presence and absence of breast PCR. So in this case, adding the axillary dissection is not expected to upgrade. And even in the ICARO trial for the isolated tumor cells, patients who underwent axillary dissection, they had only 5% additional positive macrometastasis. So the risk is not very high. And it will not change the management, because she's going to receive radiation anyways. And the addition of systemic treatment is not going to be determined on this. If she has a micrometastasis, she's going to be considered a node positive anyways.
Okay, thank you very much. And now we're going to the systemic treatment. And obviously, we're going to need the help of Dr. Rerov to comment on these next 2 questions. So the first question is whether we're going to give TDM1 in this patient or continue with trastuzumab and pertuzumab. I remind you the patient got neoadjuvant chemotherapy with trastuzumab, pertuzumab, and then she had PCR in the breast, but also had one micrometastasis, one of the 4 lymph nodes. Can we vote now, please? So the question is whether we consider the metastasis, this micrometastasis in the lymph node, as a residual disease or not in terms of taking decisions about systemic treatment. Let's get the results. Okay, 62% TDM1, 38% trastuzumab, pertuzumab. Dr. Errol.
Yeah, hi. So according to the results of the Catherine trial, we know that patients with any residual disease in the lymph nodes or in the breast derive benefit from adjuvant TDM1. So I'd be tempted to use TDM1 here in this scenario, even though patients with micrometastatic lymph node disease are underrepresented in this trial and are included in the PNX category. So I would use TDM1 definitely.
That was a tricky question, actually, because we know that there were many few patients with only residual disease in the axilla and not in the breast. So I don't know how well they are represented in the Catherine trial, these patients. And I don't know what evidence do we have that they are getting any benefit from TDM1, these patients. That's why we put this question in this.
That is correct. There were about 125 patients in this category, and when they're split, there are very, very little number of patients. However, when we look at the hazard ratios, it's like 0.16 or something, absolutely very high, but with a very wide confidence interval. But still, extrapolating the data from those who are left with, even though microscopic residual disease in the breast, so I would be tempted to use TDM1, definitely.
Okay, let's make it slightly more difficult for you now. So we have ITCs only in the axilla, PCR in the breast, and we have the same question, TDM1, continue with trastuzumab, pertuzumab, or any other option if there is any other option. So let's vote again for this one, according to what you have already heard up to now. Okay, let's see the results. Fifty-50. Okay, so Dr. Errol,
Yeah,
it's more
so
challenging now because I think we have absolutely no patients with ITCs only in the axilla and the Catherine trial. So let us know what you think.
exactly. So I would consider this patient as a node-negative patient. And if there's also no residual disease in the breast, I would continue with trastuzumab. Maybe not even pertuzumab, because this is not a residual node positive disease, but still here in Turkey, we use both the dual blockade, even if it's N0 disease.
Thank you very much. So we go to this, I think, final question, I guess. Can axillary lymph node dissection be safely omitted in patients with high nodal burden and presentation for biopsy-proven positive nodes who convert to YPD0 following neoadjuvant chemotherapy and TAT if we remove 0 out of 3 lymph nodes? So we had 4 confirmed at the beginning, and then we removed just 3, and the 3 were negative. Are we happy to avoid any surgery in this axilla? Yes or no? Let's vote. So we still know that at least one lymph node who was involved is still back in the axilla. We didn't remove this lymph node. We know that because we removed 3 out of 4. Let's get the results, please. 74% believes yes, and 26 believe no. Bahadir.
Oh, yes, that's the gray area. So what I may answer to this question, I just, mark the yes option here. Why? Because even in those patients that you are satisfied with your sentinel lymph node biopsy or TAD, there's still a remaining portion of patients with positive nodes. So we assume that it is negative, but actually 25 to 50% of those patients are remaining with the positive nodes behind. So in all those retrospective studies and 3 prospective studies, 2 from Holland, 1 Rapture study, the other one is the MARI study, and the most previous one, the other nut from Spain, they all show that radiotherapy works instead of axillary lymph node dissection, assuming that it is negative, but actually we have 25 to 50% of our patients with the residual metastasis in their axilla. So the difference is none. And even the actual number of recurrence in these patients, given the fact with the longest follow-up, which is the Rapture study from the Holland, 10 years of follow-up, is the recurrence rate is only 2.8%. So I would absolutely choose for radiotherapy in this patient.
Thank you very much, Bahadir. I think we should carry on. We discussed a lot about the axilla. We're going to be discussing more in the next session, but Michalis is going to take over. Michali?
Yes, I'm here.
You can share your screen.
Yes, I'm trying to share my screen. Can you see my screen now? Yes.
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 Fantastic. So moving on to the second case of this part, we are going to discuss about a 60-year-old patient who is postmenopausal with a C-cup breast, who presented herself in the clinic with a 16 millimeter lesion in the right breast and normal axilla. CNB, so core biopsy, revealed ductal grade 2 breast cancer, ERPR very positive, HER2 negative, and with a Ki-67 index of 10%. So a luminal type, rather luminal A, I would say, type of breast cancer, small one, 60-year-old, postmenopausal, and clinically negative axilla. And the burning question is this: very low chance of having anything in the axilla. Would we be tempted to do nothing, or we're going to stick with the book and perform a sentinel node biopsy? So SLNB or not SLNB? Can we vote, please? We have a couple of good quality trials about this question, and we have the honor and the pleasure to have the boss of the one amongst us. Can we see the results now, please? Oh, Toralf, you need to work harder to convince us. All right. Toralf, what do you think?
I'm a little bit surprised about this 50-50 result.
Yeah.
But of course, I voted for option number 2. I think this patient is a really good candidate for complete omission of axillary staging, preoperative T1 tumor stage, and intermediate tumor grading, hormone receptor positive, HER2 negative, and probably we have done an axillary ultrasound before surgery with a negative non-suspicious result. So I do not expect any additional information when we are doing sentinel lymph node biopsy in this case, because systemic therapy is clear in this case for the postoperative setting. The only thing, the only controversial point is if this patient is a candidate for partial breast irradiation alone, then probably you have to discuss the sentinel lymph node biopsy option, but only in this scenario.
Thank you, Toralf. I'm trying to find one of us who has voted for a sentinel node biopsy. Can I ask
I think
Dr.
Jamila, I think.
Jamila, yes. Tell us what
Yes.
you voted.
I did vote for sentinel lymph node biopsy, and the reason is exactly what was mentioned, is omission of radiation therapy. So based on the PRIME2 and Lumina trials, this is an excellent candidate for omission of whole breast radiation after lumpectomy. And in order to be able to apply these trials, all the trials included or mandated to have a pathological node negative disease. So if I don't perform a sentinel lymph node biopsy, my radiation oncologist will not accept to omit radiation therapy. In my opinion, omission of radiation therapy is more beneficial for the quality of life of the patient than performing a sentinel lymph node biopsy, removing just 1 or 2 nodes, and the risk of lymphedema is very minimal.
So,
if the radiation oncologist will not apply these trials anyway and they will radiate, then I will omit sentinel.
so it's a matter of decision on the radiation plan.
It's a multidisciplinary approach because eventually we're not only looking at the patient from the surgeon's perspective, we have to look from all perspectives and what is the best outcome for the patients. If my surgery is going to escalate radiation, then this is a problem. If omitting surgery is going to escalate radiation, this is a problem. And actually, there are evidence, and there is a recent study that was published last year showing that since the de-escalation of sentinel lymph node biopsy started, there was a concomitant escalation of radiation therapy, specifically to those patients who had omission of sentinel lymph node biopsy. So we are shifting the gear, we are tilting the scale. We have to pay attention to what we are doing on the other hand, not only on the surgical side.
Thank you very much. Valuable notes for both of you. Dr. Eralp has risen her hand.
Yeah, I have. Actually, although I voted for the no sentinel lymph node biopsy for this specific patient, I would like to bring into question about additional decisions for adjuvant treatment. I agree with my colleague's comment on de-escalation of irradiation. I totally agree with that. But also we know that in lymph node, even in clinically lymph node negative patients, there is a chance for missing the eligibility for adjuvant abemaciclib in like 2 to 4% and ribociclib in 7 to 8% of patients. Although for this specific patients, the likelihood for eligibility is very low, we will have to discuss the role of sentinel lymph node biopsy in patients with a higher risk for additional lymph node involvement, either with lymphovascular involvement, grade 3 disease, or a high Ki-67 of 20%. And this was my comment.
Thank you, Yesim. I add to this by noting, Toralf, if I'm not wrong, there was a small difference in the percentage of people who got chemotherapy between the two arms of Enzima. Is that right?
Yep, that's right, Michalis. We had a chemotherapy application rate of 10% in the no sentinel arm and nearly 14% in the standard sentinel lymph node biopsy arm, but without any impact on survival analysis. So probably we are talking, if we consider the Enzima population, we are talking about the low risk, low proliferative cohort, probably with no effect of chemotherapy. And I think we cannot compare the Natalie trial with a high rate of chemotherapy, nearly 88%, of all patients received chemotherapy in the NATALY trial, and then see the encema population with only 10 to 14% of chemotherapy application.
Two different populations.
Yeah.
Go on with this discussion with the very last question of this presentation. Hold your thoughts. Let's move on. What if now the alternative scenario, we have a Ki-67 of 50%? Would you go for SLNB or not? Toralf, again, I'm going to ask you.
Yeah, yeah, it's a really unusual case, this combination. No high tumor grading, but high Ki-67 index. We have the subgroup analysis from the encema population comparing low and high Ki-67.
Sorry, Toralf, I'm interrupting you. Sorry.
Okay.
Let us vote first, and then you can, take over. So let's vote. Let's vote one or two, please. Yeah, and let's see the results now. High Ki-67 index. Yes, most of us voted for sentinel node biopsy. Yes, Toralf.
Okay. Yep, we have data from additional subgroup analysis using the encema trial population, comparing low and high Ki-67 with a cutoff using of 20% with no difference regarding primary outcome analysis, with no impact on 5-year invasive disease-free survival. So we don't use this marker in Germany, in the German guidelines, to say yes or no sentinel lymph node biopsy. But in the special case here with a really, really high Ki-67 index of 50%, we have probably only limited amount of data from the encema trial because the number of patients with really high Ki-67 was very low in the encema trial.
Let me thank you, Toralf. Let me ask another citizen from Greece this time. Can I ask you, Yorgos Metaxas, can I ask you, does the value of Ki-67 play a role in your mind for this decision?
I don't think it plays a role in this case, but I would probably go for a sentinel lymph node biopsy.
Okay, so you would go for a biopsy anyways?
Yes.
Okay, thank you. And moving on, sorry. Now we have a high grade tumor, so grade 3, again ERPR positive, HER2 negative with a Ki-67, relatively low. I remember that from the encema trial, the grade 3s were only 3 or 4%, if I'm not wrong. And from the sound trial, equally a very small amount of patients had such a grade 3 cancers. So let me change now. Let me go to Bahadir. Bahadir, what's your take on this?
It's also an unlikely scenario, as Toralf said, for the second one, because when you have a grade 3, tumor with this high, percentage of hormonal receptors plus HER2 negativity with a Ki-67 less than 20%. But, this is our practice, but I would like to, send this pathology to another pathologist to say whether this is grade 3 or not. But assuming that this is grade 3, all right? So here, what I'm just, my decision making here in two ways. One is the local control. So I don't think that grade 3 doesn't mean anything for me because this anatomical, we're looking for an abnormal lymph node here. Ultrasound and clinically, if it's negative, by making, having a tumor like grade 3 doesn't mean that you will have high likelihood of having an node positivity in the axilla when the ultrasound, a good ultrasound and a clinical examination is negative. But here, the thing is, if your systemic treatment will be changing by doing a sentinel lymph node biopsy in this patient by finding a positive node, and maybe we may do a sentinel lymph node biopsy. But now I'm turning this question to Yeşim. Why? Because she is the medical oncologist here. If, let's say, this patient had a node negative, sentinel node is negative or positive, because of this grade 3, would she choose to do an Oncotype DX or any genomic assay before deciding a chemo? I know that not only by lymph node, because this patient is postmenopausal, 60 years old, doesn't mean that up to 3 node positive means a chemotherapy in this patient. But
Right.
maybe it would
I'm going
be.
to stop you here, Bahadir, because you are giving up the next slide.
Really?
Yes.
I'm sorry. All right. Okay. So my decision here that I may omit sentinel lymph node biopsy here in this case as well.
Before voting for this, because we should vote on this as well, Toralf, what would you do? Very briefly, is it grade 3 a reason to do SLNB?
In this case, I would vote for option number 2 for standard sentinel lymph node biopsy because we have a limited data from the Enzima trial. But in the forest plot, there can be a disadvantage for this small subgroup of patients with tumor grade 3 regarding primary outcome analysis. So, option number 2.
Okay, and let's now vote. Let's see if you have convinced the audience. Let's vote, please, SLNB for a grade 3 tumor or omission of it. Let's vote. Can we have the poll box, please? Thank you, and let's see the results now. Yes, so it's a major win, this one. So grade 3 is a reason to proceed to sentinel node biopsy in this patient. Thank you. I said it is going to be trickier and trickier. So same patient, but now has not a ductal type of cancer, has an lobular type of cancer. And we're asking this because we know that is a relatively more rare type of cancer, usually underrepresented in trials. And as we all know, it is tricky. It is not well seen in the imaging. So the question for the audience is, for a lobular breast cancer, which is clinically negative in the axilla, would you do a sentinel node biopsy or not? Let's vote, please. Let's see the poll box. Lobular. And the results, please. I see. So we go back to what we know for the cases we're not sure about. I will try to find someone who insists on no sentinel node biopsy, but for now, I would like to ask Konstantinos Zachariadakis to give us a UK perspective. Konstantine, are you here with us?
Here. Well, as per our guidelines, we don't follow the sound trial. We would normally offer SNB, but I actually voted no SNB, and just because it's lobular, I wouldn't necessarily, do a sentinel lymph node biopsy. But currently, the UK guidelines ask for a SNB in these cases. They're about to be updated, but they haven't yet. I think we're a bit slower to adopt these de-escalation strategies.
Right. Moving on to Nicola. Nicola.
Yeah, yes. The question is always what is the risk of understaging this axilla and how this eventual understaging will impact on the choice of adjuvant treatments. And we know that the risk of understaging an axilla for a lobular cancer is higher than for non-special type cancers. We are around 18-20% of N1 patients in CN0 patients. So probably I would go for a sentinel lymph node biopsy, even if we are here in Italy, we are great users of the sound in SEMA criteria. But in this case, for lobular cancer, I would go for sentinel lymph node biopsy.
Thank you, Nicola.
Yeah.
A question.
Michalis, sorry to interrupt, because I have been answering the same question all the time. Just to clarify, when we say HER2 equals 1 cross, is score 1 and it's negative. Because everybody's asking, why are we doing all these things for HER2 positive patients? This is a HER2 negative patient.
Negative.
Score 1. Just to clarify, because I keep answering this question in the question and answer box, just for everybody, this is a HER2 negative patient. Score 1 is negative. Sorry for the interruption, Michalis.
No, that's all right. I said it when I presented the case. It's HER2 negative. Yes, I said the luminal type. My question would be then, Nicola and everyone, would you like or would you find useful a more advanced imaging method to give you the piece of information you are possibly missing for the axilla? Would you do a PET-CT, for example, to make sure that...
I recently read the results of the SOAPET trial. Yes, but I don't know if, and they concluded that a PET scan for all CN0 patient could add some information, but I don't know if it would be a good option doing a PET scan for all patients and how much this will improve our staging. I don't know. What is the opinion of the other panelists?
Jamila, you have raised your hand.
Yes, thank you. So especially for lobular carcinoma, I don't think PET-CT will be beneficial or will be cost effective, because we know what is the mechanism of action of the PET-CT. But the other thing that is worth paying attention to is actually the higher Ki-67 now. It's not only invasive lobular, but also the Ki-67 now is 25%, which is above the threshold of the studies. And also this makes the patient a luminal B rather than a luminal A, which then precludes the omission of radiation therapy. So this patient will receive radiation, and that's why I would omit sentinel lymph node biopsy in this patient, because even the false negative rate in SEMA trial after sentinel was only 5%. So the likelihood of having additional nodes is not high. And it was like around 12 to 13% of each arm in the NSEMA that had an invasive lobular carcinoma. So I would still apply the sound and NSEMA trial.
Toralf, what's your take on this?
We have data from the NSEMA trial. The rate for the subgroup with invasive lobular disease is quite high, with 13%, with no impact on the primary outcome analysis between the subgroups. And sound and BOG trial, the rates for lobular patients are 8% and 10-11%. So we have data. We have to wait for the meta-analysis, but today, we include patients with lobular disease as candidate for complete omission of axillary staging. This is a little bit conflicting with the ASCO guideline.
And you don't use PET-CTs or any other advanced,
No PET-CT in this case.
All right, thank you all. We haven't voted about this. Let's see what the audience says now after the discussion. Can't we have the poll box, please? Yes, we have. Sorry. Yeah. All right. Sorry about that. Yeah. So it is approaching to the end of this presentation. The question now that arises is really, does this extra information about the axillary status, does it matter for patients with grade 3, high Ki-67, or high-risk genetic signature? I'm asking this because for these patients, we know more or less that they will take chemotherapy. So do we really want to dig into their axilla to find there if there's any positive node, or the decision for adjuvant treatment has already been taken? And for that question, I would like to hear the answer by Dr. Eralp as a medical oncologist.
Yeah, so are we going to vote first? Sorry.
Sorry, again, yes, sorry. Let's vote, people. For the audience, let's put the poll box on. Poll box, please. Can we have the poll box for this one?
No, this is not the one. We need the new poll box just to vote. Okay, thank you.
Yeah, this one. So if we're pretty sure that she will have chemotherapy because she has a high-grade cancer, high Ki67 or positive genetic signature, do we need to go to dig into her axilla for a sentinel node biopsy? Yes or no? And let's see the results now, please. It is yes for most of us. And Dr. Errol, do you want to comment on that? What did you vote?
Yeah, I actually voted no, but the answer may differ according to what we're looking for. If we're looking for the answer for the question whether this patient, whether additional info would provide information regarding chemotherapy, I would say probably not, because let's say the odds ratio of finding additional information with regards to chemotherapy would be in the range of maybe 2 to 5% for this patient. It's lower than 10%. However, this would differ whether we're looking for the answer of whether she would be eligible for additional abemaciclib or ribociclib. For this question, we would possibly say yes, because from the trials, as we know, the sound and the enzema and others, they have not included patients who have received adjuvant CDK inhibitors. So for this, I would say yes, but for the chemotherapy question, I would probably say no, because we know that in the long term, and sentinel lymph node biopsy does not result in a change in oncologic outcomes mostly.
Thank you very much. I would like to take the opinion of a surgeon, so I'm going to ask Dr. Poulakaki, Fiorita. I know it's a tricky question, but I want to ask you, what would you do in this case? Would you do an SNLNB only because we're used to it and because it's easy, or decide that you don't need it because it's probably a chemotherapy patient anyway?
No, I would definitely go for a sentinel lymph node biopsy in this case, because we know that this group of patients have high recurrence in the future, axillary recurrence, not high, but higher than those that have lower grade and lower K67, or they have a low risk of genetic recurrence. I would definitely offer for these patients a sentinel lymph node biopsy.
Thanks, Fiorita. Moving on, and this is the last question, specifically for lobular cancers. Does the extra, although we have partially answered this question, for lobular cancers, would you certainly go for a sentinel node biopsy or not? So does the extra information about the axillary status matters for these patients who have cancers that are not visible in the imaging? Yes or no? Let's put up the poll box, please. And the results So yes, we have discussed about it before, so we have answered this question, we have commented on this one. It seems that lobular cancers are cancers that are not convincing for the omission of SLNB in this case. So I think I will stop here and I will give the microphone back to Sophocles. Thank you very much.
Okay. So as we move to the final session of today's webinar, I would like to shift the focus now from the guidelines and multidisciplinary recommendations to the realities of surgical decision making, actually. So the cases and scenarios that follow are not necessarily questions with a single correct answer. Rather, they represent situations where evidence may be limited, evolving, or open to interpretation, and where experienced surgeons may choose different approaches. So many of these decisions are influenced not only by the tumor biology, as you will see, and the clinical data, but also by surgical judgment, technical expertise, patient preferences, and of course, the assessment of the risk and benefits. That's why we're going to need mostly our surgeons to be here and discuss their preferences. So our goal is not to determine who is right or wrong, but to explore the reasoning behind different treatment strategies and to understand how experts approach these challenging situations in the daily practice. So we encourage you all to vote again, despite the fact that most of you may not be familiar with some of the decisions that will be presented here. But what we need actually is to see how experts think and how experts approach this case differently. Okay, so it's going to be mostly technical session now, slightly boring for our oncologist and the radiotherapist, but I think let's start and see how it goes.
But an opportunity to learn, Sophocles. Everybody can learn a bit of surgery.
Definitely. So we go one of the most common scenarios these days, the irradiated breast. So it's a true case, this one, of course. 61 female postmenopausal patient with a big cup size, P+ cup size. She's not smoking, family history, mother of breast cancer in the age of 70, and otherwise healthy. On 2024, she had a DCIS of 2 centimeters removed from the right lower inner quadrant of the right breast, and it was high grade, ER negative this time. What she had at that point was a wide local excision plus central lymph node biopsy, which was 0 out of 3, and then she underwent radiotherapy. 2 years later, she comes to us having had a BRCA test, and she was found to be BRCA2 negative. So this is the patient's photos. So as you can see, this is the incision. I don't know if you can see my pointer in the irradiated breast, and this is the irradiated breast on the right side, and you can see it's a B+/C cup on the left side. So this is the mammogram. We can see the irradiated breast on the right side on the CC and MLO projections. So I'll give you some time to see the mammograms. And then we go to the first question. How would you manage the breast at this point? Do bilateral nipple-sparing mastectomy and reconstruction, no further surgery, or bilateral skin-sparing mastectomy and reconstruction? As always, I would like the panelists to comment only on this question because there are lots of questions coming up. So we will not like to ruin the next of the scenario. Just answer and comment just on how would we manage the breast at this point, the decision making. Let's vote. Let's get the poll box on. So would you go for nipple-sparing mastectomy, no further surgery, or skin-sparing mastectomy, both with reconstruction? So let's get the results, please. So as always, divided. No further surgery, 36%, despite the fact that it's a BRCA2 patient, a 47% nipple-sparing mastectomy, and a small percentage skin-sparing mastectomy reconstruction. Fiorita, what would you vote? What did you vote, and what?
I vote for no further surgery since this patient is above 60 years of age And we know that what we offer to the patients, even BRCA positive with a prophylactic operation, the benefit is not that huge as young patients. I wouldn't offer further surgery to these patients since we can always follow her up. And since she already had radiation in the right breast, which is some sort of prophylaxis for her.
Thank you very much. Thodori.
Yes, I agree with Fiorita. This patient has fewer remaining years at risk, but I will refer her to a gynecologist. Now, obviously, we'll have to discuss it with the patient because if she's fit and well and she wants to have surgery, prophylactic mastectomy discussions are still relevant at the age of 60.
Thank you very much. Nicola?
Yes, I also voted no further surgery, but I agree with both my colleagues because I think it's a matter of shared decision making. We will not have any advantage in terms of overall survival for this patient, but is a matter of shared decision making. If the patient desires to undergo a prophylactic surgery we know that it will not impact on her overall survival, but she has a higher risk of recurrence or new primaries or better. So if she would like to undergo these, she should be very well informed that having undergone already radiotherapy, the reconstruction part of this mastectomy could be particularly challenging and it's at higher risk on the right side. So in a proper shared decision making, we could consider both options according to the patient desire.
Thank you very much, Nicola. We have, though, Florentia with us now, who's going to be the expert to discuss the genetic part.
Yeah, so when it comes to her actual risk for getting another breast cancer, this is like less than 10% for the rest of her life. So that's not a very big percentage. This is attributed to BRCA2 and her age. So actually her risk is not as high to offer bilateral mastectomy. And considering that the reconstruction, as already said, is going to be an issue in her based to the previous radiation, I think that this should be thoroughly discussed with her prior to a decision that's going to have some difficulties. The other issue that should be discussed, I know this is a breast surgery-based conversation, but we should never forget that women that do have BRCA1 or BRCA2 mutation have a really high lifetime risk of getting ovarian cancer. And this risk never goes away. So to my view, and if we consider life-changing decisions, I think what should be offered to her would be bilateral salpingo-oophorectomy rather than mastectomy.
Thank you very much. Michalis.
Sophocles, allow me to ask Florentia something. Florentia, what is the age, the cutoff point above which you would not recommend a prophylactic mastectomy and below which you would say you would agree? This is my first one. And second, I think when considering these cases, it is not only the survival we have to take into account, it is the risk of second disease, because a second disease is more chemotherapy, more surgery, etc. So, Florentia, do you want to give me the age limit above which? Thank you.
So we now have data relating to breast cancer and the women that are aged after 60. So even if you have a BRCA carrier that didn't have any breast cancer history at all, so we just know that she's a BRCA carrier, we now know that her breast cancer risk after the age of 60 does not exceed 20%. So even if you have a BRCA carrier that never had cancer, her risk of getting breast cancer is 20%. This is again not as high as expected, probably to offer preventative surgeries. As again, I said earlier, this does not apply to ovarian cancer risk. Ovarian cancer risk never goes away. And what was the second question?
No, there was no second question. That was it. The second was just that we have to take into account the bad experience of a recurrence, not only the,
You're right.
the survival.
Okay, I think Bahadir wants to make a short comment before we move on. Bahadir?
Yes. Regarding the second question of Mihailis, we need to change our perspective, Mihailis. You're suggesting that there might be a 10% of recurrence rate in future that the patient may require a second surgery. But now, at this point, you're suggesting 100% of chance of doing a second surgery right now to prevent a 10% of recurrence. So from the perspective of a surgeon, we always biased. Now you're suggesting maybe a 90% of the time is a, unrelated thing maybe to the topic here. So it's a, way that a surgeon sits with the patient as a shared decision making. You need to discuss all the complications and the consequences of doing a so-called prophylactic surgery at this time as well. Not only considering a future risk of maybe here in this case, it's less than 10% in order to avoid those complications for futures, because the patient will carry all that burden after that surgery as well.
Thank you very much, Bahadir. So the patient had this shared decision making and she decided that she definitely wants to go for, I don't know why I was saying this whole box now. Okay, so she decided to go for prophylactic mastectomy. She was insisting on that despite the fact that she was informed about the complication rate and etc. etc. So in this case, what would you offer? Nipple-sparing mastectomy plus autologous reconstruction, nipple-sparing mastectomy plus implant-based reconstruction. Let's vote. Okay, let's see the results, please. So it's almost 50-50. George, Metaxas.
Right. Thank you. That's very interesting. I think that this patient is actually an excellent candidate for a more specialized technique, a robotic approach. In case he agrees to have an implant-based reconstruction. I understand that autologous may be considered an option when somebody is irradiated. However, I would, in a 60-year-old patient, I would start the conversation with simpler techniques, not straightforward surgeries. And from my point of view, I would discuss a tissue expander on the right side, submuscular or full muscular pocket, good coverage. And on the left side, she could have a pre-pectoral or a subpectoral implant dual plane. She has a very good subcutaneous plane.
George, don't ruining the next of the case. Just answer,
Sorry.
what would you do? Autologous reconstruction or implant-based reconstruction? That's the question.
Implant-based.
Implant-based reconstruction. Nicola.
Yes, well, it's a matter of shared decision making, because we know from the literature that autologous tissue-based reconstruction in patients who have been previously irradiated is the gold standard in order to reduce the risk of complications. But again, not all patients would like to have scars in other parts of their body, or they would like to undergo major procedure, as a DIEP flap could be the option in this case. And also we should think that she had a very badly placed incision for the previous surgery. So also this could be the decision driver for the choice of the incision for our mastectomy. So I would not be sure in one direction or the other, but I would talk thoroughly with the patients, and again, together with her, I would look to her to her values and preferences in order to have a shared choice. But I can tell you that in these patients, we would go for autologous tissue in preference.
As you said, this is the gold standard, of course, but
yeah.
Primarily is not highly available, and secondary, patients hesitate to go for such a big operation, as you said, for such a low risk of recurrence. So if we had only implant-based reconstruction available for any reason, this is why I stopped George before, because George started answering this question, which is exactly all the options we have in our hand. Either do subpectoral expander with a total muscle coverage, subpectoral plus mesh and expander, subpectoral plus mesh plus implant, direct to implant, prepectoral and expander, prepectoral plus implant, direct to implant. So we have all the options available here. And let's see what are the preferences and then discuss all these available options. Shall we get the poll box, please? So let's see the results. Okay. I will start with somebody who will support subpectoral. Who would like to support subpectoral placement of the implant? Jamila, would you like to support that? No. Toralf?
No, I voted for number 5, prepectoral.
Prepectoral, thank you. Thodoris?
I voted for prepectoral, but not as one stage with an expander.
We have Giuseppe with us, I think. Giuseppe, are you here?
Yes, but just connected. So I
Okay, I'll let you for the next question then.
Yes.
Okay,
in
then. So
principle,
Fiorita, what do you think?
I voted for subpectoral and expander because, first of all, we have a bilateral case, and in this case, we need to have choices. We need to have a lot of choices because we will probably in the left breast, we will do a direct implant, and we need to have choices how it will expand and how it will become after the previous irradiation. And also, I think it is the safest way to avoid skin necrosis and to, even if the skin doesn't go, the healing process doesn't go very smoothly, we always have the possibility with the expander to go a step behind and leave it deflated for a longer period in order to leave time for the skin to heal. I think this is the perspective that gives the lowest proposition of
Complicated.
Can you hear me?
Yes, definitely. Yes.
Okay. I think this approach with the subpectoral expander, the 2 stages, not direct implant and mesh, give us the least possibilities for complications.
Thank you very much, Fiorita. And George, I think, raised his hand. So, George, can you continue with what you left behind before?
There are two different things. The right breast is an irradiated high-risk breast, so I would go definitely for a subpectoral expander in the first place. And either at the same time or at the second stage of the first operation, I would go on the other side, if possible, for a prepectoral polyurethane implant, because the other side has a very, very good, a very thick subcutaneous plane and is ideal for prepectoral placement. So yes, I would expand the right side and see how it goes, and then probably I would put an implant.
Michalis?
Quick question. George, would you use a mesh for the expander placed under the muscle? And have you ever found that the pec major is a bit, you cannot stretch it because of the radiotherapy?
In my limited experience of a few irradiated breasts, that was not an issue, the expanding of the muscle. And I would preferably not use a mesh because I would use a full muscular pocket because there is also a small deformity at the level of the medial to lower breast, so there's no fat there. So I would like a full tissue coverage of the expander and the implant in the long term.
Thank you, George.
Jamila?
Yes, I voted for prepectoral expander, mainly on the right side. We saw from her mammogram that the thickness, the Rankati, is acceptable. It's only that area of scarring that has loss of fat. So I believe we can go for prepectoral tissue expander to expand that area, and later fat grafting also to improve the thickness in this area and the contour. At the same time, I would like to avoid using any meshes in a radiated breast. However, this breast doesn't look like it suffered a lot from radiation. We can see the quality of the skin on the picture. It's good. The radiation has been like 2 years ago now. It's not like recent radiation. So I would like to stay above the muscle, and on the other side also prepectoral, either DTI or tissue expander.
Thank you very much. Here you can see the Rancati as it was mentioned by Jamila and by everybody else. So there was some thickened coverage of the muscle of the glandular tissue. So obviously candidate for prepectoral, as everybody said. So this is the patient on the table. And obviously we are open to discussion, tips and tricks. I will ask Nicola actually. Nicola, where would you place your incision in this case, and what would you actually plan for the right breast?
Yes, no, my opinion is that mostly if we decided with the patient to go for an implant-based reconstruction, so this is the starting point. So if going for an implant-based reconstruction, my decision-making would be the same of a patient that would not have not been irradiated. The point is, I think that the Rancati and the comorbidities and the smoking habit of the patient, apart from the radiotherapy, would be the major drivers. In this case, we had a good Rancati. She's not a smoker. And probably, as also Michalis mentioned, the pectoralis major is affected by previous radiotherapy, and it could be fibrotic. So I would prefer not using the pectoralis major. I would not use an ADM. I don't think that it would improve our outcomes. And I would agree with Jamila that a so-called hybrid reconstruction would help us, because we have evidence that fat grafting could improve also the tissue quality, also in irradiated patient. And as for the incision, this is a tricky case, because we had a very badly placed incision at the inner quadrants for the previous surgery. But probably I would not use, even if I usually use the same incision we had before, but it's a very badly placed incision. It could be not useful to use this incision, and I would prefer to use an inframammary fold lateralized incision for this patient, in order not to go in the inner quadrants. This is my opinion.
Thodoris, would you place your incision lower or in the same level as the left breast on the right side? On the irradiated breast, would you place your incision the same level as on the normal breast, or would you place it lower or higher?
No. I would place it a little bit. I will try to place it a bit higher, to be honest. But I agree that I wouldn't try to use the previous scar. I will go for an inframammary fold too.
Okay, so the initial plan here was to do whatever you said, just use the muscle to cover the implant, etc., etc. But as Michalis said, the muscle was completely non-movable. It was fibrotic, stuck to the chest wall. It was very unusable. So the plan changed, and we went for prepectoral reconstruction here. So what if we go to the one and only what if we had a large proptotic irradiated breast, would we try to preserve the nipple? So let's say that this patient had a very big breast and was irradiated. It was not a BC cup, it was a D cup plus. Would you go for preserving the nipple, yes or no? Let's vote on this, please. Again, irradiated right breast, previous operation 2 years ago, same quality of skin, same quality of radio, of mammogram, but very large breast. Let's see the results. 50-50. Okay. Nicola, you are the master of preserving the nipple. So what do you think?
No master at all. But anyway, in my decision making, previous radiotherapy would not change my my decision making in preserving the nipple. I think that even if previous radiotherapy obviously had an impact on the vascularity of these flaps. I think if you properly perform the mastectomy according to the anatomy of the breast, and if you properly preserve the vascular network, the superficial vascular network, probably using the triple pedicle skin-reducing mastectomy, I would not change my opinion in preserving the nipple only because the patient was previously irradiated.
So you would preserve the nipple in this?
I would preserve the nipple. I would preserve the nipple on a triple pedicle mastectomy, skin-reducing.
Anybody against, Nicola? Who has the courage to stand against Nicola?
Okay.
I would stand against Nicola, and I would refer the patient to go to Nicola to preserve her nipple.
Okay, thank you, Fiorita. I would welcome your patient.
Giuseppe, would you preserve the nipple in a very large ptotic breast irradiated previously?
Yes, why not?
Yes.
Well, we normally tend not to do implant-based reconstruction in previously irradiated patients. So we normally tend to turn these patients to an autologous tissue-based reconstruction, whether this can be with a DF flap or with another autologous flaps. Autologous flap may be an LTAP, sorry, a TDAP, depending on the donor size. And obviously, in this case, you will have tissue underneath in which the nipple can engraft. But most of the times, I don't. Again, as Nicola said, I don't see the point to removing the nipple.
Thank you very much. So this is what happened with this patient. These are the results 1 month after the operation, or 1.5 months after the operation. As you can see, left breast is quite okay. Right breast, there's this fibrotic tissue in the lower inner part doesn't allow the implant to get lower. So obviously there's a need for a little bit fat grafting in this area, unless if you want to. There's no question here, it's just discussion. What would you offer to this patient apart from fat grafting? Would you offer her to change the implant, do something else, modify anything?
Fat grafting.
Fat grafting.
Yeah.
I think so. Okay. Okay, so at this point, I'm going to actually...
Just to mention, we have a trial about hybrid breast reconstruction. So you can use it on the first surgical time, a tissue expander, and then deflate, and then use fat grafting to replace the volume of the tissue expander.
Okay, she has tissue expanders, so it can deflate, fat graft, and then inflate again? Okay,
fat graft 2-3 times, and then finally complete with a
inflation again.
Well, it's hybrid, so you will put a smaller implant underneath.
Can I ask a question to Giuseppe?
Yes.
Did you find good results in radiated skin in this? Because the problem with radiated skin is the fat take is not as much as the normal skin. So multiple sessions of fat grafting sometimes doesn't work that well. I would think of the fat grafting not as a replacement of the volume rather than contouring to avoid grafting large amount of fat. And have you used anything to enhance the fat take in these patients?
Nothing to enhance the fat intake. Again, the first indication is for autologous tissue, and agree with you, yes.
Has anyone tried this CO2 gel?
No.
I know Rancati, he uses the infiltration of CO2 before fat grafting to enhance the affinity of oxygen, but there is some new products with CO2 gel that you can apply and it all on the skin, having the same concept, but I haven't tried it yet. I want to know if anyone has.
No.
Thank you.
So,
No
Michalis.
experience with this. Sorry.
Thank you. We have tried a few things, but I think nothing works very well. Local treatments, etc. Thank you, Sophocles. Let's move to the next case. Let me try to share my screen. I hope you see my screen now. And we're going to discuss about a 52-year-old woman postmenopausal with a known genetic mutation in BRCA1 gene. And this patient presented to the clinic with a lesion in the right upper outer quadrant of the breast, right breast, a small one, 9 millimeters, clinically negative axilla. This was biopsied and it was a triple negative cancer. She is not a smoker. She has a BMI of 28. She has a family history as a BRCA positive patient and has no other medical issues. She is a cup size D. She has a significant, as you can see in the photo, ptosis of the breasts, and she has no previous scar on the breasts. And in the upper right corner of the slide, you can see her mammogram. And here it is again. And the first, and her MRI scan here down on the left side. And we discuss about it. She wants to have a mastectomy with reconstruction because of her BRCA positivity. The first question that arises is, would you again preserve the nipple in her or not? Let's see what the audience says first, and then we'll discuss about it. Can we have the poll box, please? Not a smoker, not very obese, healthy otherwise. Should we try to preserve the nipple? Let's see the results now, please. The vast majority of us voted for yes, we should try and keep the nipple. Let me ask what the panel says. Jamila, what do you think we should do with her?
I would still try to preserve the nipple. As you mentioned, she doesn't have a lot of clinical risk factors, although her Rankati is not the best. You can even see the veins on her skin. It's thin skin. However,
don't ruin the rest of it. So I'm interrupting here. Sorry for that. But we have similar questions in the next slide. So you would try to preserve the nipple. Is that right?
yes, multi-pedicle preservation.
Yeah. Don't.
Okay.
Yes. Okay. So you would try to preserve the nipple. She has no comorbidities, not a smoker. All right. Let's take the opinion of Nicola. Nicola, would you try to preserve this nipple?
Okay, you already know my answer. Yeah. Sure. I would go for nipple preservation. Yeah.
I'll take it as a yes. Let's go on with opinions. Theodoros Kodoulis, if you're with us, would
Yeah.
you try? Is it reasonable? Yes.
It's a reasonable yes, because so far it looks straightforward that we can try to preserve the nipple. Yeah.
Bahadir, would you preserve this nipple?
Although I'm not an oncoplastic surgeon like Jamila and Nicola, but my plastic surgeons would definitely go for nipple preservation in this case as well.
Yorgos Metaxas, would you preserve this nipple in this case?
Yes, I would definitely offer the nipple preservation.
I cannot find a no, but I'll give up now. Let's move on to the next question, which is why I stopped Nicola from going on with his answer. Let's talk about the technique now. For large ptotic breasts, there are several techniques published on the internet. So I'm asking you now, which one you would prefer? I know that the techniques we use heavily depend on our own experience, heavily depend on patient's characteristics. So let me ask you, would you go for the 3 pedicle based nipple sparing skin reducing mastectomy like Nicola Rocco has published? So 3 pedicle based nipple sparing skin reducing mastectomy? Or would you go for an other type of wise pattern mastectomy with a single or double nipple pedicle? or you would prefer image this one, the middle one, with a double batwing. We have published it. It has several advantages and disadvantages. So option number 3. Or you would go for a two-stage reconstruction, two-stage procedure, that is reduction first and then the mastectomy with the reconstruction. Or you would go for a free nipple grafting, so remove the nipple and then put it on the correct spot. Or any other answers, or you would definitely would not go for nipple preservation in this case. I would like to for the audience to vote now, and we're going to discuss about it later. Vote, please. Thank you. I'm going to let a few seconds more because it's a complex slide, a complex answer. So typical wise pattern, 3 pedicled, double batwing, 2-stage, free nipple grafting. Right, I think time is up. Let's see the results now. Nicola, you won. You won. Can you let me ask you, Nicola, something?
Yeah.
For this 3 pedicled based nipple reconstruction and skin reducing mastectomy, is there any factors that you would anatomical factors that would not allow you to do it?
Okay, I would like, yes, I will answer your question, but I would like also to comment to the other techniques. Anyway, we at the beginning in our first experience, we only used this technique for Rankati 3 patients when we safely could go for a prepectoral reconstruction, because this is a technique that you can do only for together with a prepectoral reconstruction. Now we are pushing a little bit with the experience, the technique, and we are also using this technique in Rankati 1 patients when the quality of the mastectomy flaps is very good and we don't have other comorbidities of the patient or smoking habits of the patient. And also we are pushing the technique in terms of lifting of the nipple. So in terms of how much we can lift up the nipple. Sometimes you can struggle a little bit to close the mastectomy when you completely leave all the 3 pedicles. But we are now using also the possibility of using the Doppler in order to find where the perforators run within the dermal flap towards the nipple, in order just to spare the perforators and just to do some very small cuts on the dermis flap in order to better mobilize it. It will not be a dual pedicle, but there will be some cuts on it in order to better mobilize it upwards. Anyway, I would not consider a double batwing technique. I don't like it because it also consider an incision that goes in the upper inner quadrant, that is in the so-called social area of the breast that could be exposed. So I would not prefer this technique. So, and sometimes also when we need a lift of more than 10 centimeters, we could opt for a free nipple grafting. But I would not consider a traditional skin sparing mastectomy with a nipple only on the superior pedicle. We experience very high rates of nipple ischemia and necrosis.
Thank you, Nicola.
Yeah.
Thank you, Nicola. Let me ask Theodoros Kodoulis, what would he do in this case?
Well, I don't have much experience in this technique, so I think that Nicola described it very well. I wouldn't like the batwing technique for the same reasons going to the upper inner quadrant. So I would prefer one or two to do, even though that free nipple grafting looks much safer if we want to ensure that we will preserve the nipple.
Thank you, Thodos. Jamila, what's your take on this?
I usually do the triple pedicle technique. However, as Nicola mentioned, you need a good Rancati because actually the pedicle run in the subcutaneous tissue. So the thicker your flap, the more likely to preserve the blood supply. So I will choose this option. Otherwise, if the treatment plan in general for the patient allows, I would do a therapeutic reduction first. With contralateral reduction mastopexy, I will remove the tumor, do the sentinel, reduce the whole nipple breast while preserving the glandular tissue to provide more blood supply. And then later I can do a nipple sparing mastectomy with implant.
Okay.
Before radiation.
Yeah, thank you. Let's move on now to
I
the
think
next.
Giuseppe and Zachariadakis want to say something before we
Okay,
move.
yes, of course. Giuseppe.
Yes, as I said before, we have this trial about hybrid breast reconstruction. So typically these are women with high BMI that they have very good fat donor areas. So we tend to do, we tend to preserve the nipple as a triple pedicle technique, but we don't use the expander as a one-stage procedure. We use the prosthesis as one-stage procedure. And we use the tissue expander, we deflate the expander, and we use the fat that is very generously present elsewhere.
Thank you, Giuseppe. Costadine?
Yeah, thanks, Michalis. So I voted for option one, which is the tripedicle, the WISE pattern. Now, I've used the tripedicle, I've used your technique, or like the double bat wing. I think it's a very good technique, the double bat wing. The difference for me, deciding whether I would do a tripedicle, a WISE pattern, or the double bat wing, has to do with the shape of the breast and how the technique affects the breast. So in a WISE pattern, you reduce the width of the lower pole. This doesn't happen in the double bat wing. So if you have an elongated breast that is ptotic, you don't really need to reduce the width. So you would get an excellent cosmetic outcome with a double bat wing technique because you would just shorten the upper and lower pole without affecting the width. But if you have a wide breast and you decrease the upper and lower pole, you would end up with a breast that looks like a rugby ball, like elongated, like that. I think the breast that you showed, either technique would work fine. Like the WISE pattern would end up with a good cosmetic outcome. I think the double batwing is a very safe technique. I've used it less times than I've used the WISE pattern, but I've had like for carefully selected patients that have like a more elongated breast, you end up with a very good cosmetic outcome in my opinion. Like the cosmesis of the breast, the shape that you end up with. So I think either that's the only reason I raised my hand. I think that in that case, the double bat wing would work fine because it looks like a very elongated breast.
Thank you, Costadine. Let me just put in my experience here. Double bat wing is, Nicola is right. It creates a scar in a place where we don't want it. It has the advantage of having zero complications, very small number of complications, even in patients that are very, heavy smokers, obese, diabetic, etc. So it has, good results even in these patients. And you will be surprised how little this scar is visible. It depends on when you put it. You put it just kind of under. And Konstantinos very cleverly saw it that if you want to reduce the length of the breast, I think this is a very good, and not the width of the breast, this is a good option. But thank you for your comments, all of you. Moving on to the next one, next slide now. What will happen in this case? It's a real case, by the way. It's a real case. The only difference in this case, please ignore it, is that this person has a scar there. Ignore the scar. Imagine that there's no scar there. So what would you do if you had to do with this patient, very ptotic, very large breasts? Would you dare a nipple preservation, or you say no, play safe, no nipple preservation? Let's vote first and then we'll discuss on it. Can we have the poll box, please? Okay, let's see the results now, please. We're much more reluctant now because of the lift we have to do to the nipple. Let's ask our panelists. Jamila, what did you vote this time?
I hope, I wish there was a third vote for free nipple graft in this case.
No. The question is here, would you preserve the nipple or not?
No, I did chose mastectomy without nipple preservation in my head that I would do a free nipple graft.
Free nipple grafting is a nipple preservation, kind of.
Not really. It's
Okay,
just a
but
skin
we're
graft.
going to discuss about the technique on the next slide, like we did before. Okay, Nicola.
No, this is a very difficult case because I think we should lift the nipple areola complex of more than 9 centimeters, more than 10. Well, if the patient has not major comorbidities, she's not a smoker, she has a very good Rankati, we could push, but I think this would be a little bit too much. Probably I would go for a free nipple grafting. But anyway, I would try for a nipple grafting. I never consider to remove the nipple, and I inform the patient, we try with a nipple grafting and we will see.
Theodore?
No, without nipple preservation in that case, for sure.
Okay, play safe. Giorgos Metaxas?
Well, if I had to do this, I wouldn't offer nipple preservation. I would consider nipple graft, but not nipple preservation on the skin of the breast.
Mm-hmm.
Thank you. Fiorita?
You know my answer. I wouldn't offer nipple preservation. I would consider nipple grafting at a later stage.
Bahadir?
Only by grafting, the same answer to.
Oh, you all ruined my next slide. There you go. So in this case, we ask the same questions as before. 3 pedicles, wise pattern with 1 or 2 pedicles, double butt wing, 2-stage, free nipple grafting, any other, or I insist, no preservation.
Michalis, I think it's going to be 80% a specific number.
Let's see. Can we vote, please? And the results now, please. Free nipple grafting is 51%. Right. Let me ask the panelists. Is this the let me free nipple grafting? How would you prefer it over a reconstruction, a nipple preservation with nipple preservation in its nature? That is, would you prefer it over a double butt wing technique if this double butt wing technique can produce safe results, no complications? What do you think? I want to ask, is free nipple grafting a last resort for nipple preservation? In your opinion, last resort. Nicola, what did you vote?
No, I voted for free nipple grafting, yes. But anyway, for the skin reduction, I would go for a wise pattern. But I'm not against your technique. It is just because of my habits. And then I would preserve anyway a long dermal flap in order to better cover the implant. I would anyway use the dermal flap, but I would go for a wise pattern reduction and then the free nipple grafting. Yes.
Jamila, what did you do?
Yes, same. In my experience, I do a wise pattern. I don't have the experience of performing the double batwing technique, and I'm thinking with a lot of skin laxity, then we're going to end up with a dog ear that is very medial anyways, and it will extend the incision in the medial portion of the breast.
Thank you. Thank you, Jamila. Now, what if the thickness of the mastectomy flap is very thin? Would you insist with nipple preservation or not? You see how thin it is. Let's vote first and we'll discuss then. And let's see the results now, please. Okay, so a thin subcutaneous layer seems to be a reason to avoid nipple preservation. Okay, Nicola again.
No, I have a strong opinion on this, that I would never, I would preserve the nipple because if you properly perform the mastectomy according to the anatomical planes, even if you have a Rancati 1, all the vessels will be, all the superficial network will be over the anterior lamina and will be in this very thin subcutaneous tissue. So I think it's a matter of quality of the mastectomy flaps, and it's not a matter of thickness of the mastectomy flap. Even a very thin mastectomy flap could have a very good quality and a very good vascularization if the mastectomy has been properly performed according to the mastectomy, to the anatomy of the fascial layers of the breast, the anterior lamina of the breast. So in my decision making, there is not the thickness of the flap, but if the mastectomy is properly performed, is on the quality of the mastectomy flaps.
I so much agree with that, yes. Georgios Metaxas, what is your take on this?
I think I would agree with Nicola that it's independent of the thickness of the flap, and it has to do with the vasculature and the good preservation of the plane during dissection.
I agree. It makes it more difficult.
Yeah.
More challenging, but it's not a reason to avoid it. Fiorita?
I would dare to preserve the flap in this case. And another reason, apart from what the colleagues mentioned, is that the Rancati here, it doesn't seem very ptotic, this particular image. So I think we don't have a long distance to lift up the breast in this case.
Okay, I think it's a way the photo was taken, because you know when the breast is between the plates, it can change the. But you are right, it's a good observation. And what technique would you use for that? Will you change your technique because of the Rancati score?
No,
Let's
not really. Not
No.
really. I would prefer a wise pattern technique here as well.
Okay, let's vote first and then we'll discuss about it. So let's vote, please. A thin subcutaneous fatty layer will change our take on this strategy. And let's see the results, please. So no, more or less we answered the same things. Well, thank you everyone for this participation in this presentation, and I will pass the microphone to Sophocles.
Okay, so we don't have much time left, so we modified a little bit the program, and we're going to discuss two short cases now, me and Michalis. Obviously, we're not going to do the miscellaneous part, but I think these two cases are quite interesting because we're going to go slightly away from what we have discussed up to now. So the next case, hopefully, is going to be the right one. It's a 50-year-old premenopausal patient with a C cup size who on the screening was found to have one lesion on the right breast, 17 millimeters on mammogram and ultrasound. So just to show you the lesion, this is the lesion on the right breast. As you can see, this is speculated area, and there's a small tiny area in the ultrasound. This is the only thing that was visible on the ultrasound. Nevertheless, she had an MRI. We do MRIs for all these young patients who are going to go for wide local excision. And this one showed, as you can see here, a multifocal area spreading in a total of 6.7 centimeters in the whole outer part of the right breast. It showed this combined lesion of 3.5 centimeters and multiple satellite foci here, which was apparent as a non-mass enhancement. The biopsy from the lesion that was visible on the ultrasound was invasive lobular carcinoma grade 2, ER positive, PR positive, HER2 negative, Ki 67%, typical luminal A cancer. And just to clarify, we also took biopsies via the MRI, so all the area from the top to the bottom was the same thing. So this is the patient, and that's the area as you can see on the breast of the patient. And my question is, what do we do now? Breast conserving surgery, nipple sparing mastectomy construction, skin sparing mastectomy, and reconstruction. So let's vote. Let me see who's on board here. Okay. Okay, can we see the results, please? So most of us would actually offer wide local excision for multifocal cancer, which is an evolution because many years ago, not many years ago, 5-6 years ago, most of us would have gone for mastectomy for this patient. But I'm glad to have changed and evolved as surgeons. And I would like Giuseppe, what do you think?
I agree. We have so many options for breast conserving surgery in this lady, no doubts. And also the disease is localized on one side of the breast. So breast conserving surgery, yes.
Okay, I'm not going to waste more time for this question because obviously we agree that we're going to go for wide local excision here. So during the planning of this patient, there was a bracketing of the lesion. So on the superior part, there was a clip placed on ultrasound, and on the most inferior part, there was a clip placed on MRI. So we managed to do a bracketing of the lesion before the decision making about what operation to do. So considering this and having that in mind, let's vote whether we could go for a WISE local excision, WISE pattern, for a skin-reducing mastectomy for those who voted for skin-reducing mastectomy, plus minus nipple preservation and reconstruction, other oncoplastic resection, or a localized perforated flap, wide local excision with a LICAP, for example, or any other local perforated flap. So let's vote. I would expect to get everybody divided with this question and get lots of answers here. So I will probably spend most of my discussion on this question here. So let's get the results, please. Okay, so 50% would go for a WISE pattern wide local excision, 30% would go for a perforator flap. And I will definitely start with Theodoris Kondoulis.
Yes.
I know your answer, but I would like to listen to your answer.
Okay, therapeutic wise pattern most probably is the default oncoplastic option, but I would choose a perforator flap, an L-tap or a LICAP, because first of all, it's eptotic breast, but not too large. We don't have to operate on the contralateral breast. We can preserve the native size, and we can preserve breast aesthetics. It's much better when we have localized lateral defects when we're using an LTAP. That's wise I would discuss it with the patients to have a perforator flap than a wise pattern, unless she wants to go smaller and she wants to have a symmetrization procedure.
Thank you very much, Doris. Jamila.
Yes, I also selected the WISE pattern for this case for reduction, but however, it is a shared decision making. It depends on what is the patient's preference, if she wants to do anything on the contralateral side, or otherwise we will do chest wall perforator flap in order to avoid operating on the contralateral side. However, in my practice, I have problem with the boost and the radiation boost after the chest wall perforator flap. The flap is usually dermocutaneous, so most of it is fat. And when I send the patient to radiation oncologist, they boost almost everyone, and I have necrosis and loss of volume in the flap, and it's really headache to correct that afterwards. So I would lean more towards a WISE pattern unless the patient wants nothing done on the other side.
Thank you very much. So we carry on with the next decision. So my question is, if you didn't have an MRI and you didn't get the clip done, how would you remove this area? For everybody, the question, Josh.
I
If you
think
didn't have the MRI and you had
it is
only a
yes,
visible
I think
lesion, yes.
I'm very reluctant always with this pattern of appearance of the cancer in the breast. And I think that in order to do breast conserving surgery, you have to be confident that you have a good bracketing of the tumor area. Otherwise, I think it's better and safer to do a mastectomy. So if you didn't have an MRI, I think you would be literally blind in this patient.
Exactly, that's my point. So Fiorita, what do you think? If you didn't have the MRI opportunity to get the clip on the lower part and just bracket the area, how would you do wide local excision in this patient?
I would definitely try to have an elastography or
it was tried. It was nothing.
Second look ultrasound and nothing appeared. Yes, probably I wouldn't feel safe enough to keep the breast in that case if I didn't have the opportunity to put a clip under MRI.
Okay, Jamila, you raise your hand?
If we didn't have an MRI, then we wouldn't have discovered that there are 9 lesions. We would have only seen one lesion, and we would be tempted to excise it, right?
No, I mean the MRI placement of the clip and the biopsy.
You mean we did an MRI and we couldn't do an MRI placement?
Exactly.
No, I don't think I would be able to do a breast conserving surgery in this case, especially if it's a lobular carcinoma. Then I will push the patient for a mastectomy. I cannot just guess. As you said, we're going to go blind.
Excuse me, but if we don't have the means to do oncoplastic surgery, we don't do oncoplastic surgery. We play safe. The hypothesis is that we have the means to localize all the lesions and to know where they are. Otherwise, we're not sure that we have healthy margins.
Yes, exactly. So it all depends on what availability you have in your system. That's why I'm discussing this case, because everybody assumes that it's easy to get an MRI guided placement of a clip here, which is not the most common thing to happen in every system. Okay, so the patient, as you said, she requested to get a breast reduction and a lift up. So this is what happened. It was a bracketing. This is the one clip. This is the other clip. This ultrasound guided clip, MRI guided clip, the 2 wires placed inside. And as you can see here, this is the area as it was visible in the MRI. Somebody needs to turn off the microphone. There's somebody with a microphone on that actually makes some noises.
And plays the guitar.
Plays the guitar.
Okay, whoever plays the guitar, please just turn off the microphone. Later on, you're going to have the chance to perform for everybody. And these are the final results of the patient. So that's all for me. And we'll carry on with Michalis on the last case.
Sophocles, I think everybody's tired, to be honest.
Okay.
We have prepared a lot of cases, and we could go on until tomorrow. But I see that everybody's getting tired, and perhaps, and besides, it's exactly 4 o'clock. So for a change, we could call it a day on time.
I wouldn't agree more.
So I think we owe you a huge thank you to everybody. As I said, there's a lot of work behind the preparation of this webinar, which is not always visible. So thank you all for your hard work on this. Thank you, our usual participants. Thank you to our new participants. And of course, thank you to the audience who had the stamina to bear with us all these 6 hours. Sophocles?
Yes, on my turn, I would also like to thank everybody for joining, all these people who actually spend this nice day by being here with us and contributing to it. I was impressed with most of the answers today because they actually create a lot of discussion. Thank you, everybody, all the returning customers and all the new ones, and especially our faculty, the new ones and the old ones who have been here with us. We hope you enjoyed it as much as we enjoyed it. And hopefully next year, you're going to be here with us too. Michalis, would you like to say anything?
Thank you, everyone.
Shall we?
Thank you, everyone. We hope we'll see you again next year. Thank you all.
Have a
Thank
nice
you.
afternoon.
Bye-bye.
Thank you.
so much. It was a pleasure.